For decades, the dominant model for addiction recovery was defined by a specific, non-medical tradition, unassisted abstinence. Within this framework, sobriety is often viewed as a feat of endurance, a process of overcoming withdrawal and cravings through sheer willpower and mutual support. This tradition fostered a deep-seated skepticism toward medication-assisted treatment, or MAT. The central ideological objection suggests that using a prescribed medication to treat a substance use disorder is essentially replacing one addiction with another. This chart, however, reveals the consequence of that skepticism. Clinical evidence shows that MAT protocols like methadone maintenance decrease mortality among users by roughly 50%. The medical data is clear. Stabilization via medication is one of the most effective predictors of survival. Despite these life-saving outcomes, MAT remains drastically underutilized across the American treatment system. Many facilities and practitioners continue to prioritize philosophy over pharmacological interventions that are proven to reduce relapse risk. This creates a significant disconnect when the preference for a non-medical approach overrides clinical evidence. The treatment system effectively ignores the biological reality of how these substances interact with human physiology. Medical researchers define substance use disorder as a chronic health condition. It carries a strong genetic component, placing it in the same clinical category as type 2 diabetes or hypertension. Long-term substance use alters the pathways of the brain's neurocircuitry. These shifts in the neural network govern survival and reward, leaving the system highly dysregulated. This is the primary failure point of cold turkey detoxification. These neurocircuitry pathways do not simply revert to a normal state once the substance is removed. The brain remains conditioned to expect the chemical input long after the system is clear. This is where medication-assisted treatment becomes necessary. It functions as pharmacological scaffolding, providing the stability required to bridge the gap between a dysregulated state and long-term recovery. When the biological circuits governing survival are compromised, willpower alone is often an insufficient tool for repair. To achieve a stable outcome, the brain requires a biological stabilizer. Modern MAT protocols are divided into two clinical objectives. First, attenuating the physical agony of immediate withdrawal, and second, inhibiting the euphoric potential of the drug to prevent relapse. We look to the neural receptor where opioids interact. A full agonist, like methadone, triggers complete activation, satisfying dependence without erratic spikes. A partial agonist, like buprenorphine, occupies the space but sends a much weaker signal to the brain. This creates a ceiling effect. Because activation is capped, buprenorphine is significantly safer than full agonists, as it is far less likely to cause fatal respiratory depression. Then there are antagonists, like naltrexone. These bind to the receptor but do not activate it at all. Instead, they occupy the site to ensure it remains blocked from other molecules. The result is that if a patient relapses, the receptors are already occupied. The illicit opioid cannot bind, and the patient experiences no euphoria. This protocol requires precise timing. As shown in the clinical guidelines, a patient must be drug-free for 7 to 10 days before starting an antagonist. If opioids are still in the system, naltrexone will immediately displace them, triggering severe acute withdrawal. This distinguishes between medications used for the short-term management of withdrawal and those required for the long-term reduction of cravings. Opioid MAT works through the targeted engineering of receptor activation. It is a biological solution to a biological crisis. While opioid protocols focus on the receptor site, treatments for alcohol use disorder often target the body's metabolic processes. Consider disulfiram or antabuse. It doesn't reduce the urge to drink. It alters how the body breaks down alcohol metabolically. It inhibits a specific enzyme, so if a patient drinks, a toxic byproduct rapidly accumulates, making them violently ill. This mechanism relies on negative reinforcement. The physical penalty for drinking serves as the primary deterrent. Acamprosode operates on a different principle, targeting the neurological craving itself. Long-term alcohol use disrupts the balance between the brain's glutamate and GABA systems. Acamprosode helps stabilize this chemical imbalance, reducing the persistent drive to consume alcohol. Naltrexone is also used for alcohol disorders, but for a different reason. It blocks the release of the brain's own opioids that normally make drinking feel pleasurable. Contrast these options with the treatment for stimulant use disorders, like cocaine or methamphetamine. Withdrawal here is defined by severe lethargy and depression rather than physical sickness. Despite the severity of these conditions, this clinical text confirms a major gap. There are currently no medications with FDA approval to treat stimulant use disorders. While we have neurochemical tools to stabilize patients with alcohol or opioid disorders, the absence of a stimulant AMT highlights the boundaries of pharmacological treatment. Beyond the molecular level, patients must navigate the external reality of their recovery environment. Clients often face intense pressure from peers or sponsors who believe that using medication means they are not truly sober. This sociological stigma remains a primary barrier to successful treatment. This pressure creates a dangerous situation. If a patient impulsively stops their medication to satisfy peers, they lose their biological stabilization and often relapse within days. Clinicians must encourage patients to view AMT with objective detachment. It is a medical tool, no different than using insulin to manage diabetes. Selecting the right protocol requires a detailed analysis of the patient's history, their specific health profile, and their liver and renal function. Informed consent is vital to this process. Patients should be taught to ask these specific questions to understand the purpose, the side effects, and the risks associated with their medication. Identifying the right molecule is only part of the solution. Protecting the patient from ideological stigma is just as important for their long-term retention and treatment. No medication is a standalone cure for addiction. The primary function of MAT is to serve as a biological stabilizer that creates a window of motivational opportunity. In the early stages of recovery, physical cravings and withdrawal consume a patient's entire cognitive load. When the brain is focused on survival, therapeutic work is nearly impossible. Medication reduces that cognitive load. By stabilizing the baseline, it provides the mental space necessary for a patient to engage in behavioral therapy and build new coping mechanisms. Pharmacology manages the immediate crisis. This gives the patient the time and stability required for behavioral changes to take root. When we map the timeline of modern addiction treatment, we can see how these elements integrate. We begin with the dysregulated brain chemistry of active use. Phase 1 is detoxification. Long-acting agonists are used to safely taper physical dependence and prevent dangerous withdrawal complications. Phase 2 is maintenance. The protocol shifts to antagonists or partial agonists to protect receptors and aggressively reduce relapse. Phase 3 is integration. With biology stabilized, the patient can finally engage in long-term behavioral therapy and build a new support network. Detoxification by itself, without a plan for long-term stabilization and therapy, offers almost no lasting value. To deny a patient these pharmacological tools based on an ideological preference is to reject the findings of modern neuroscience. The only empirically sound standard of care is the combination of medical stabilizers with behavioral intervention. Substance use disorder is a medical condition defined by the brain's physical circuitry. To save the patient, we must be willing to treat the biology.